Hello and welcome to this video. This is the third in a series of videos, so hopefully you've seen video 1, which is the theory behind our patient assessment. Video 2, we looked at the cardiac arrest patient, and in this video we're going to be dealing with the conscious patient. But again, we're still going to follow that same theme as we go through. So any incident that we attend, we've already checked our equipment and our bag, and we know everything is up to date and in sterile packaging, which is great. We then get called to attend a patient. So we will make our way, and on the way there we will be continuously doing a dynamic risk assessment. But on arrival at the scene specifically, we're going to stop, and this is where you may take your bag off of your back. And once you've stopped, you are then going to think about what you need to do. The thinking is your dynamic risk assessment before you do anything. And the dynamic risk assessment we're going to use comes from the JR Calc, known as the scene assessment. So we're going to be looking for overall safety. This may include PPE. So at this stage, we may want to put gloves on, remembering we only need gloves for bodily fluids, and actually I can't see any bodily fluid, so I'm not going to put my gloves on there. We may need to wear masks, we may even need to wear goggles as well. But what I am going to do is just use some alcohol gel on my hands at this stage, and while I'm rubbing that in, I will carry on with my dynamic risk assessment. I'm looking to see if I can see any other elements of danger for my own safety, the safety of the patient, or the safety of any bystanders. I'm also now considering the cause. What has caused the patient to be here? I'm looking at the environment. Has that got an effect on it? Is it particularly warm, particularly cold? It's different things that I need to consider. Numbers of patients. Do I need to triage who I treat first? There is only one patient, so I'm happy to proceed. Do I need extra resources? Not at this stage, but I might want to put somebody on standby just in case. So maybe a radio call in to a colleague to make them aware I'm attending a patient. Now I've done my scene assessment, I'm now going to go into my primary survey. And at the beginning of that, I'm going to do the AVPU. I'm going to see whether the patient is alert. And as part of this, I will be introducing myself and letting the patient know my grade. Hello there, my name's Jason. I'm a medic with ERS. How can we help you today?
I'm really dizzy.
Okay, and what's your name?
Abby.
So, all I've done at the moment is establish a rapport with the patient, making sure I'm staying at the side and not coming in from in front. I've told them my name and I've told them my grade. I've also found out why the patient is here, their presenting complaint, and I found out their name, getting ready for my ATMIST handover at the end of this. I now need to go into my primary survey, but on this occasion the patient is alert. So if they're alert, that tells me they've got an open and clear airway. They are breathing, they have got circulation. Their new disability is they're feeling dizzy, is what the presenting complaint is. And I now need to go in and examine the patient to get some more information. If I would have seen any catastrophic hemorrhage, I would have put the correct PPE on and dealt with that straight away, but we'll be looking at that in another video. So we're going to carry on with this scenario, and I'm going to ask the patient, so I'm going to gain consent to get permission to do some checks on the patient. Abby, is it okay if I do a couple of little checks on you just to see what's going on today?
Yeah.
Excellent. How old are you, Abby?
17.
Abby's 17. So, we've got consent. Is it alright if I put this on one of your fingers? I put it on this finger here. On this SpO2, we just need to switch it on, pop it on a finger there. She has got nail varnish on the other fingers, so we've avoided them, and this one. I'm not even going to look at the results at the moment. I've also got my fob watch handy, so I can look at this. I'm going to leave my fob watch attached to my bag, so I can actually got a counter, or I may get my stopwatch on my phone. Is it okay if I take your pulse, Abby? Abby thinks I'm taking her pulse. I'm not. I'm counting her respiratory rate. So what I'm doing is just watching for abdominal movement where the diaphragm is, or even chest movement up here, but Abby won't be distracted because she thinks I'm taking a pulse. So I look at my watch, look at the seconds, and when I get into the breathing pattern, I then are going to do this over 30 seconds. However many breaths I get in 30 seconds, I will double that to quote it per minute. So on Abby here, we've got 7 breaths in 30 seconds, so that will be 14 breaths per minute, and we know that the average, as per the JR calc, is between 12 and 20 breaths per minute. I'm now going to take her pulse, and I could, so if I just take the pulse on the other arm, Abby, so can I just have this arm? So I'm going to come in here, I'm going to come down onto that radial pulse, making sure my thumb isn't in the way at all. I've got a really nice pulse there, and again, I'm now going to get my timer. For the pulse, I could do this over a minute, I could do it over 30 seconds. I'm going to do this one over 15 seconds, and I'm going to count how many beats there are. So we've got 20 beats in 15 seconds. Times that by 4, Abby's got a pulse rate of 80. I'm going to have a look at the SpO2 now, and we've got 76 on the SpO2. I'm going to write down what I had, so I would get my paperwork out at this stage, make sure I've got a black pen, and I can start to write down these observations that I've just taken. So we make sure we know the time, we can put down the respiratory rate of 14, we can put down the pulse rate of 80, and the SpO2 is 93%. Well, that may be the reason why Abby is feeling a little bit lightheaded, because her oxygen levels are a little bit low. So Abby, is it okay if I put a little bit of oxygen onto you? Abby's consented to having oxygen, so when we open up our bag here, we've got our oxygen masks. I've got my non-rebreather mask, which would be for critically ill patients. That's not what we've got on this occasion. I've got my simple face mask, which would be for seriously ill patients. So when the SpO2 was down at 85%, that's not what we've got. And then we've got our nasal cannula, which we're going to use, and this would be for Abby, which we're going to use. We're not going to put this one on today, but I would check with the patient, get consent. The 2 little prongs would go up the nostrils and come around the back of the ears. If you just hold on to that for me, Abby, and then what we do is we make sure that we connect it to our oxygen, and I'm just going to make sure it's turned on at the side here, so that would now turn on. I'm just going to put this onto 2 litres, so this is all flowing, everything's nice and contained, and everything is still where I need it. So Abby's got the oxygen flowing, and because of that I leave the SpO2 on, and I can see that the SpO2 has come up to 96% already, so I might turn this down to 1 litre as long as I keep it in that range, and I'm just going to keep it on nice low flow oxygen. So at the moment we've currently done our ABC. She's got an airway, she is breathing, she's got circulation. So now I'm back into disability. So Abby, you said that you're feeling a little bit faint, and now you're going to tell me a little bit more about that. So I'm going to ask some questions. I'm looking at my ample here. Abby, have you got any allergies to any medication?
No.
Any allergies to anything at all?
No.
So no allergies. Do you take any regular medication, prescribed or otherwise?
No.
No. Do you have any past medical history?
No.
Have you ever felt like this before?
Yeah.
Yeah, so when was that?
A while.
A while. And what happened on that occasion?
I fainted.
Okay, so what we're going to do, Abby, if it's okay with you, just because you're feeling the same, is sit you down on the floor now, just in case you do faint again. Is that all right? Would you like to pop yourself on the floor? Yeah? Well done. So all we've done is we've just thought about our positioning because of the patient and their history and what might happen from that. So we're going to now carry on with our ample assessment. When was the last time you had anything to eat or drink, Abby?
I had breakfast this morning at 10 o'clock.
And what did you have for breakfast?
Toast.
And is that normal for you?
Yeah.
Yeah, excellent. So we're just establishing that there. And what happened today? Can you just describe the events leading up to me coming in?
I was just walking around, I was tidying my bedroom, and then I suddenly felt really dizzy, so I sat down and called you.
Excellent, there we go. So we've got the history of what's going on. And have you got any other kind of history? Any medical history? Any medical conditions? No? Excellent. So we've now got that. Abby, would you mind if I do a couple of other checks on you? Would you mind if I have a look in your eyes? Okay, so I'm just going to get you to turn and face me slightly. And the first thing I'd like to do is just cover up each eye at a time, if I may. Okay, so what I've done is I've just looked at Abby now. I'm looking on my pen torch here. I'm looking at both pupils, and they're about 6 millimetres. So I'm just going to cover up your left eye first. I've got clean hands. I've used my alcohol gel. I might consider gloves, but I don't need them. I'm going to cover it up, looking at this pupil, and it's growing bigger. Cover it up for 1, 2, 3. Release it. It shrinks back down, exactly what we're expecting. I'm just going to do the same the other side, if that's okay. So we cover that one up, look at that pupil, 1, 2, 3, it's growing and it's shrunk back down. So exactly what we was expecting. Because I've touched a patient, we're always going to clean our hands after and touching the patient, making sure we rub that in. If I wanted to, I could use the pen torch for checking as an alternative, and this would come on, and I'm just going to shine it in one eye at a time, so keep looking at me, comes across, 1, 2, 3, and this time it shrunk down as I expected, coming across to the other side, keep looking at me, 1, 2, 3, and that's done. So again, we would clean all of our equipment as we go through. I'm going to ask Abby some other questions, and I can't remember them, so I'm going to use my aid memoir. And on this occasion, we're going to go to our pain score. So what I'm looking for is my Socrates in my book, because we know it's in here. So we'll find this. Okay, so I've got some questions to ask you, Abby, if you don't mind. Where did I put them? There we go, so I've got this. So I'm going to ask you a little bit about some pain, okay? So have you got any pain at all today?
Yeah.
Where's your pain to? Just in your head, is it?
Yeah.
Yeah, okay. So where exactly is the pain, the site of the pain?
Yeah.
Just there. And the onset. What were you doing when the pain started?
Walking around my bedroom.
Okay. And character. What does the pain feel like? Just hurts, does it?
Yeah,
Okay, can you describe it at all for me?
Like
No?
a headache.
Okay, like a headache, good. And radiates. Does the pain go anywhere else?
No.
No? Associated symptoms. Have you got anything, other feelings?
Just the dizziness.
Okay, dizziness, okay. So you're not feeling nauseous or sick or anything like that? Good. Okay, timings, duration. How long have you had the pain?
About 20 minutes.
Okay. Exacerbating, relieving factors. Does anything make the pain better or worse?
If I hold it.
If you hold it,
My
okay.
head down.
If you put your head down, okay, thank you. And severity. So we're going to get a pain score. So would you be able to give me a score between 0 being no pain at all and 10 being the worst pain you could ever imagine? How much is your head pain at this very moment?
6.
It's a 6 out of 10. So again, I'm just going to make sure I document them bits down, including all the other information that my patient has given me on that. On this occasion, I don't believe there's any reason to do any other checks, but we could do a couple of little neurological checks depending on what's wrong with a patient. So I could do my motor sensory capillary in all 4 limbs. Abby, is it all right if I just pinch your fingernail there? So we just come across, I'm going to go above the nail because of that, pinch it for 5, returns within 2, and I'm just going to do the same on this hand. So we pinch it for 5, the colour returns within 2, I'm just going to come down here, and can you just wiggle them toes for me? Excellent, I'm just going to do it on this side, wiggle them toes for me, brilliant. So we've done a motor sensory capillary in all 4 limbs. Abby, I'm just going to get you to completely face me now, if you don't mind. And what I'm going to ask you to do in a second is put your hands out, and we're going to go through what we call a fast test. But just before that, can you give me a big cheesy smile, show me all your teeth? There we go, so we've got good bilateral facial movement, no drooping whatsoever. Now we're going to do the arms. So Abby, I'm going to get you to put your arms out, but can you close your eyes first? And put your arms out and turn them over and just hold them there for 5, 4, 3, 2, 1. Open your eyes and drop them back down. So the arms are absolutely fine. And then speech. We're just going to get you to repeat after me. You can't teach an old dog new tricks.
You can't teach an old dog new tricks.
Excellent. So everything's absolutely fine there on the fast test as well. So we're now quite happy. We've gone through our ranging test. And now what I'm going to do is it okay if I pop this back on your finger? Is it okay if I just take your pulse again? I'm now going back and repeating all of my observations. So we're going to do the airway, make sure the SpO2 is okay. I'm going to do the breathing rate, make sure that's okay. And I'm going to do the pulse rate, make sure that's okay, and document everything down again. Obviously, if my patient required any oxygen, I could give it to them at that stage. Obviously, if my patient did pass out at any stage and they collapsed, I would then go into all of my observations again. So on this occasion, I'm now going to put gloves on because of the airway, and we could consider mask and goggles. Hello, can you hear me? So we're going back through our AVPU. Wake up for me. Open your eyes. There is a little response there, so we've got a response. I don't need to tap the shoulders, but if I did, I'm just going to tap you on the shoulders. We've got flickering, so we've got good movement there. Abby's still got good colour. We can hear her breathing, we can see her breathing. I may choose to do a set of observations on her back, but what I'm going to do is just get Abby into the recovery position, just so we can keep her airway protected. So with the recovery position, the arm nearest to me comes out to the side. We're now just going to straighten out her legs, place them down. The arm from the opposite side is going to come across. The back of her hand goes against her face. We're going to go palm to palm. Just checking there's nothing in the pocket. I'm going to lift up the knee from the outside, and I'm going to use the knee to lever her over, bring the knee up at right angles, lay the arm down, just drop that all the way to the ground, make sure the airway is open. Because I've finished with the airway, I'm going to remove them gloves to go into clinical waste. I'm going to place an SpO2 on that finger there. I'm now going to do my observations again. So on this occasion, I've got my timer. I'm going to count the respiratory rate. I'm also going to do the radial pulse and check the oxygen levels. I will document everything down. I would now think about environment. I would now be getting out a blanket to place over our patient and continuously monitor our patient. I'm now going to get ready for the last bit, which is my ATMIST handover. So this would be the very last bit we would need to do. So I know from my documentation and talking to Abby earlier that she is a 17-year-old called Abby. So that would be the first part of my ATMIST. This incident happened about 10 o'clock this morning, so we've got that on there, and she's had pain in her head for about 20 minutes prior to going unresponsive on me. There was not much mechanism because it was just feeling lightheaded while she was walking around, and initially her oxygen levels were a little bit low, so we administered her 2 litres of oxygen via a nasal cannula. So that may be the very basics of my handover, trying to keep that as short as sweet, and I would then finish my paperwork, split the documentation. The bottom yellow copy can go off to the ambulance crew. I'm going to keep the top copy, which will go back to the employer, who will need to keep that for at least 7 years. Excellent. So we do hope that you've enjoyed our videos. If you would like to see any other videos, please leave us a comment at the bottom, and don't forget to share this video with other people who may also find it of benefit to them. We'll see you on the next one.